Hi, Jeremy Cordeaux in the Court of Public Opinion. I'm just on air here to let you know that we'll be live streaming the Court of Public Opinion every Friday between 9 o'clock and 12 on jeremycordeaux.com. Please join us. We'd love to have you.
Dr. Travis Brown, what is This Medical Life all about?
This is the pursuit of knowledge as we learn about diseases from the ancient times to the present day. These are the stories of medicine.
One of my favourite songs of all time, Dr. Travis Brown, is Johnny Cash and the Ring of Fire, which I mention because our topic today it starts with a ring of fire, if that's how you feel heartburn feels to you.
Have you had heartburn before?
I think I have. I'd know, wouldn't I?
Sometimes most likely you would know that you've had heartburn, but it's actually quite prevalent. But have you ever had a burning sensation in the bottom of your chest, or had really an acid sort of taste in your mouth?
Definitely I have.
Well, what we're talking about today is Barrett's esophagitis, and what the topic is it begins with heartburn.
Okay.
And so if anyone's listening, I think probably almost everyone will have experienced heartburn at some point in time. And heartburn's not new. It's even when you look back in historical cases and at some of the ancient physicians, they talk about it. We got Pliny the Elder, who's an ancient Roman naturalist. He's a philosopher in 1st century AD. Now, he called it
cardialgia?
There we go.
We'll do that, yes.
That's right. So he actually wrote about it.
Cardialgia is a burning of the stomach that causes a sensation of heat in the chest. It's caused by various factors, including overeating, eating spicy foods, and emotional distress. The symptoms can be relieved by drinking milk or taking herbal remedies, such as chamomile or mint. However, if the symptoms persist or worsen, it's important to seek medical advice, as they may be a sign of more serious conditions, such as liver disease.
And now, taking that, remember, his description's really good. Now, liver disease, that's a bit different. That goes into the other area. But this is from a few thousand years ago.
And what surprises me, the way that's written, it's like it's written in this modern age where doctors can be sued. It's a very couched language there of covering everything.
And that's the amazing thing. You about read it. But he wasn't the only one. Aristotle had his own.
Heartburn is caused by the digestion of heavy foods, especially meat, which generates heat in the stomach.
We have the Roman physician Galen.
Heartburn is a hot and bitter sensation in the chest.
And so we then look to a Persian physician, Avicenna, and he put this in a category of diseases of the cardia, and this was with stomach acid into the esophagus. And we can give examples of it. Probably the latest one that I wanted to look at from a historical point of view was William Heberdine, and he's an 18th century English physician. And he wrote in 1802 about commentaries of the history and cure of diseases.
The next symptom which I shall describe is pyrosis, or heartburn, which is very common and often very distressing. It is a sense of heat or scalding or pain or a gnawing or uneasiness at the stomach, sometimes ascending as high as the throat or mouth or spreading over the breast. It is usually caused by a full meal or by eating too quickly or by any kind of food that is difficult to digest.
And so when we're looking at this, again, it's surprising how modern those quotes sound. They were excellent, and they knew what this heartburn was, and they were able to work it out. Now, we know the risk factors. What we're talking about is gastro-oesophageal reflux disease. We call it GORD. Americans call it GERD because they drop the O. That's the difference. And look, we know people who are at risk, people who have obesity, they have people who have a hiatal hernia, so that's a diaphragmatic hernia. If people are pregnant, and that's because, again, pregnancy, you alter actually the shape and the way the stomach lies.
Right, yeah.
And so we also know things like large meals, having late at night fatty fried foods, spicy foods. Sometimes alcohol and coffee can be factors.
This just sounds like a Friday night to me.
Well, then you're going to take aspirin. Aspirin can cause it. And again, even smoking. And the reason why they talk about smoking is smoking sometimes can just actually relax, the chemicals relaxes the sphincter down at the bottom of the esophagus. And that way you get the reflux. And so the prevalence of this is quite striking. When you look at it, it's estimated 10 to 20% of Western populations experience this. Interestingly enough, less than 5% of Asian communities have it. And there is significant geographic variation. So depending on where you live is also important as to if you're going to get gastro-oesophageal reflux. And as we said at the start, this is not actually about heartburn. This is actually about Barrett Oesophagitis, which is a disease, but it comes from long-standing gastro-oesophageal reflux disease. And so the problem with heartburn being so prevalent, even if a small percentage of people with long-standing heartburn progress to Barrett Oesophagitis, then that can still be a pretty significant number of people who are at risk. And what we know, about 5% of people who have long-standing, or what we say chronic, gastro-oesophageal reflux disease will progress to Barrett Oesophagitis. Now, to fully understand this, we need to know a little bit about anatomy and histology. And so if you look at the gastrointestinal tube, it's actually a hollow tube from mouth to anus.
That's a lovely description, but yes.
And so what we have is your mouth's job. Each segment will have its own job to do. And so your mouth is to chew the food and to mix it with saliva and to swallow it down. Well, the esophagus is just pretty much a tube that transports it to this stomach where you get acid and mucus and all kinds. It's separated by a sphincter there. Mm-hmm. And so when we look at this is the area that this disease resides. And so what happens is you have the esophagus and the stomach. Now, they are lined by two different cell types, pretty much. And you have squamous epithelium in the esophagus, and that's actually good. That's squamous epithelium's on our skin, and we have keratin, and that's to protect. It's actually quite durable. Mm-hmm. Now, we don't have keratin in our esophagus, but it's squamous epithelium, so it can be protective. It's actually, it's pretty much designed to stretch and squeeze food through. But in the stomach, we have mucosa. And the reason why that is different is because you have acid secretion, but it also needs mucus secretion to protect its own lining
from the acid.
Exactly. The problem with this disease is that the contents from the stomach, which are very acidic, can come back up into the esophagus. And so the problem is acid, as anyone will tell you with reflux, it actually hurts a non-protected environment. And so what we're looking at is this causes constant exposure of the acid into the squamous epithelium of the esophagus.
Which is not a good recipe.
Not at all. And the body's reaction to this, obviously, aside from just the acute part, which is pain and discomfort, is the cell types over time will change. It's what we call metaplasia. And with that change, it goes from this squamous epithelium to an intestinal type mucosa, which resembles often what we say is the mucosa of the stomach and the duodenum. And so when we look at that, the first documented case was a pathologist in Boston in 1906, and they had 3 patients that he said had, quote, peptic ulcer of the esophagus, and wrote of the close resemblance of the mucous membranes about the ulcer that was normally found in the stomach. And so this was a bit confusing. How is this sitting there? This brings us to the 1950s with the Australian-born surgeon. His name was Norman Rupert Barrett. Now, he actually worked predominantly at St Thomas Hospital in London, but he noticed when he was doing his surgery that when he looked down the esophagus, there was a columnar epithelium. Now, he called it histological gastric type. Now, this was in the esophagus, and this didn't make sense. How is this sitting here? Now, his theory at the time, in the 1950s, was a congenitally short esophagus, and essentially the development had kind of pulled the stomach mucosa into the chest cavity. And you can understand how
I would have made the same mistake.
And so a few years later, though, in 1953, Allison and Johnstone, they looked at 7 patients and they thought, no, this isn't actually that. This is esophagus lined by gastric mucosal membrane. And so they disagreed with Norman Barrett. And they called it lower esophagus lined by columnar epithelium, sort of a bit of a mouthful as a quote. Now, this eventually was accepted by the surgeon, by Norman Barrett, in 1957, and through the mysteries of however names come about, it's been named now Barrett Oesophagitis or Barrett esophagus. And so it wasn't until the 1980s, though, that we started to realise that these patients actually had a risk of developing cancer because of this. And this is why we're going to have our guests on to help us understand a bit more about Barrett esophagus and Barrett esophagitis.
All right, here we go. Dr. Tristan Rutland is an anatomical pathologist at Liverpool Hospital and based at Western Sydney University. He has a subspeciality interest in GI pathology. In 2020, he was the recipient of the Conrad Muller RCPA Outstanding Teaching Award, and in 2022 received the College of American Pathologists Resident Advocate Award. He's also the Associate Editor for Social Media for Pathology, the Journal of Royal College of Pathologists of Australasia. Dr. Rutland's also a regular guest here at This Medical Life, and we welcome him back today. Hello, Tristan.
Thank you so much for having me back again. It's always a pleasure.
We look forward to it, and I'd like to start with the obvious question. What is Barrett esophagitis?
So Barrett, well, as we were talking about, we do drop the S off these things. Barrett esophagus is essentially where we have a change in the esophagus from the normal epithelium, which is squamous epithelium, which I'll elaborate on a little bit more, to a more columnar, more a sort of like intestinal, well, gastric sort of type, intestinal type of epithelium. So it's a change, essentially. It's a metaplastic change. And we call that Barrett's esophagus. And the problem, which we'll talk about, I imagine, a little bit later on, is that can then progress into something a bit nasty, which we then call Barrett's dysplasia, and then that can turn into Barrett's adenocarcinoma. But in a very, very sort of like short sort of form, it is essentially a change in the esophagus where one type of cell changes to another as well.
So then looking at the prevalent, how prevalent is Barrett esophagitis?
Yeah, that's a really interesting question. So the prevalence is really one of these things that's a bit hard to sort of really sort of find out exact numbers, but most of the Barrett's esophagus will be picked up in people that suffer from, heartburn, reflux, GERD as well. And when you someone goes for an endoscopy that has reflux or a GERD, they tend to find about 10%, maybe it's in that sort of area, plus or minus 5% of patients can have Barrett's esophagus. But when you sort of extrapolate that out to the whole population, it's probably about 1.5% of the general population. Now, the interesting thing is, and once again, it's all about, you have to look about how these studies were done. But one thing I was reading, interestingly, that the incidence of Barrett, and this is in the US, of Barrett esophagus has increased by 28-fold since 1965 to 1997, which is really quite a huge increase if you think about that as well. But then I suppose you have to sort of flip into all the factors of like, how were they picking up back then and what were the techniques and so on and so forth? Because obviously things have changed and also definitions have changed. But regardless of that, there has certainly been an increase in it. So the prevalence has increased, and it is probably about 1.5%. We talk about the whole of the population as well. But in that particular group of people that get reflux, it's talking about, 1 in 10-ish sort of people as well.
Mm. So then Going back to just first principles, what is the actual pathogenesis of this disease?
Yeah, so that's a really good question. So to really understand the pathogenesis of Barrett's esophagus, to understand, why, what metaplasia is. And what happens essentially is that we know that if you have reflux, reflux is acid going into the esophagus and even a little bit higher. That really the cells there don't like it, because you've got to think about what sort of cells line what parts of our body and why we have those cells lining it. So in the esophagus, we have squamous epithelium, which is the same sort of epithelium which is on our skin. We just don't have all the keratiny flakes. So it's a robust, it's like a brick wall. So it's great for when we swallow food and things bump all the way down, from our mouth and bump all the way down and drop into our stomach. That's great. And then the stomach, we have like we have glandular epithelium, which is made up of, like a little, inverted, usually single layers of cells, and they produce acid and mucin and all sorts of wonderful things to digest and protect and all that sort of stuff. So when we get reflux from that acid in the stomach, it goes up and splashes on the squamous epithelium. And why squamous epithelium is really good at resisting stuff. It's not very good at resisting acid. Same way as if we put acid on our skin, it burns. It happens there. So the body that area gets inflamed. And as a result, the body tries to deal with that in the best way it possibly can. And what it does is it tries to change to a cell type that is better suited to deal with acid, and that is the intestines, because the intestines has to deal with acid. If our small bowel has, mucin and stuff to protect from the acid coming from the stomach, and so the stomach itself does that. So it changes, and it depends on how far we want to go into this, because there's a lot of things saying, there's reprogramming of stem cells and blah, 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 blah. But in essence, what they actually think may happen is either that, yes, some of the stem cells, so the cells that line that epithelium, that when things get damaged, they might actually, when they get damaged and they regrow along, when they've had a bit of ulceration, they might actually regrow not into squamous epithelium in the esophagus, but into that glandular epithelium to try and protect the body from further acid damage. So that is the pathogenesis of Barrett's esophagus.
So then, do we know who's at risk of developing this Barrett esophagus?
Yeah, so that's a really interesting question. So, first of all, almost all Barrett's esophagus is probably acquired, and it's probably due to what I mentioned, reflux. Okay, so people that that have the risk factors for reflux. So we also know that certain things, people that have hiatus hernias and they're overweight, and all the reflux risk factors are there. So long-term reflux, because you're getting long-term acid damage. There's a tiny, tiny, tiny proportion of people that may have a congenitally acquired Barrett's, but that's really probably not even worth thinking about as well. Interesting enough, there is could possibly be a bit of a familial predisposition, i.e. if you have, it's not really strong, but if you do have a family member that's had Barrett's, maybe you're a higher risk as well, because remember, our bodies deal with things slightly differently. So maybe they're a bit more predisposed, their body's a bit more ready to change into metaplasia if it gets a bit damaged as well. But in essence, it's people that have long-term reflux as well. So gastro-oesophageal reflux disease.
Now, we will be talking to a gastroenterologist later about this, so I'll get more into the actual biopsies and the procedure and the management later. But can I ask, pretty much essentially the diagnostic criteria, is one biopsy enough to diagnose a person? So take 10. If one of them shows intestinal metaplasia, is that enough for a diagnosis of Barrett's esophagus?
It's not as straightforward as you would sort of initially think. First of all, the diagnosis criteria can differ from country to country in regards to what we see under the microscope. But essentially, it's one of these correlations between what the endoscopist sees under, when they're doing the endoscopy, and where they sample from to what we record. So it really is requiring. So what they see, what they should be seeing, and I know Milan will probably talk a bit more about this, is that it's usually what they call this, little salmon sort of like tongues. And all that is when we look at, once again, going back to our basic principles, the squamous epithelium is a bit like our skin. It just doesn't have that, and it looks a bit paler. And then the intestinal mucosa, which is more glandular, tends to be a bit more fleshy or a bit more salmon. So we can actually see they can see the change. And depending on how far up the esophagus will dictate on whether it's Barrett's, if it's greater, usually greater than 1 centimetre is a bit where they get a bit worried about. And then they need to biopsy those areas and then send it to us, those areas they suspect that is Barrett's. And it's usually above the gastro-oesophageal junction. And then under the microscope, we will look to see what we can see. Now, in Australia and the US, what we really want to see to make that diagnosis is something called goblet cells, which is a type of cell that you normally find in the small and large intestine. That's ones that really produce a lot of mucin. And that is what we call, that's what goblet cell, which is a type of intestinal metaplasia. In Japan and Europe, or in England, in the UK, is they don't require that. They just require that squamous epithelium to have changed to a more glandular type of epithelium, the columnar-lined epithelium. And they don't require the presence of those cells. I know that sounds silly, but there is different. Now, when we dig into that, it's probably a bit of a sample thing. So if you actually take probably enough samples, you will find maybe some goblet cells. But you don't necessarily in those countries, like in Britain, you don't need to have the presence of those particular cells. If you've got the presence, there is epithelium that looks like it's glandular and it's in a place that the endoscopists think is Barrett's. In that country, it is fine, but in this country, we need to have those large small intestinal goblet cells. We need to see that. That said, they suggest you actually, and once again, Milan will be able to say more about this, but for small segment, for 1 centimetre or so, they want 4 biopsies. The more biopsies we can get, the better, and then greater than that, I think it's like 8 on. Pathologists always want more tissue. That's our catch call. The catch call to pathologists is more tissue, please. But yeah, so just to make sure, because there probably is a bit of a sampling thing there. So we want to be able to find those goblet cells, and we can say yes, that fulfills our criteria, and it matches with what the endoscopist is seeing.
Yeah. So one of the things that I've noticed, and this tends to be for gastroenterology pathologists, is the significance and the distinction between low and high grade dysplasia. And this is just a very difficult area for someone who hasn't looked at many. But can I ask you, what is the significance of low and high grade dysplasia?
Yeah. So I suppose the thing is to really wind back just to briefly discuss about Barrett's esophagus and why we get worried about it, and Barrett's dysplasia and why we get even more worried about it, is that so metaplasia, just going back to the whole metaplasia concept. So why metaplasia in itself is not, initially has thought to have mutations in the cells. It is a pre-malignant condition, i.e. that the chances of you developing something nasty in that are a lot higher than, say, your normal sort of epithelium. And that is actually true for other parts. So, for example, in the stomach, we have intestinal metaplasia that increases your risk of getting stomach cancer. And if you think about the cervix, there's that transition zone, which is the metaplastic zone. That's where you get cervical cancer, but that usually needs. So we're worried about Barrett's esophagus, and we're worried that it will turn into cancer. And the cancer that turns up is going to be an adenocarcinoma, because it is going to rise from those glands, not from the squamous epithelium. It's the transformed epithelium into that glandular one. And there is always a risk, and there's usually a stepwise progression. So we have the Barrett's esophagus where we get that intestinal metaplasia. So it's still mature. It still looks like you could, that is something that you would see in another place that, it looks like hasn't got any, it doesn't make you think that it's got, crazy mutations. It's a mature type of epithelium. When it starts to get dysplasia, that's when you're starting to get mutations in that epithelium, and it starts to look, dysplastic, i.e. the cells look a bit more crazier, because they're starting to look a bit crazier. They're small, they tend to, small, they tend to be larger, they tend to be darker, they tend to get a lot more mitosis, i.e. they're starting to accrue mutations. And the problem is that as they accrue more mutations, the risk of turning into an adenocarcinoma of the esophagus is much higher. So it's once again, on that sort of using, very long-winded to answer ask a very short question, but essentially there is a difference between Barrett's esophagus, low and high-grade dysplasia, and each one of them has a stepwise increase in developing a esophageal adenocarcinoma, which are, as you know, very nasty cancers as well. Yeah, so there's a bunch of different studies, and it depends when you read. But for example, for high grade dysplasia, which is the upper end, it's almost turning into cancer as well. There are some studies that suggest that over 50% of people that have high grade dysplasia can progress to cancer in 5 years as well, and the cancer incidence per year. So then the chances is about, you would think, about 6% or even greater as well. And then if you look at, say, low-grade dysplasia, the chance of you developing cancer, if you've got low-grade dysplasia, is probably many times higher, 5 times, than someone that doesn't have any dysplasia as well. So that's the reason why. So low-grade dysplasia and high-grade dysplasia are bad. High-grade dysplasia is worse. And it'd be very interesting once again when you talk to Milan, because he does these resections, the way that they are now treated, because, they can treat, he'll talk about ablation and all sorts of stuff, and they can even resect areas of these things. But my job is to report, what is low and high grade, because there is obviously some serious significance with the difference between those particular dysplasias as well.
So, Tristan, what would be the key features of a report that general practitioners should be looking out for with a biopsy of this nature?
Yeah, I suppose the most thing is just to really make sure that if someone has got a diagnosis of Barrett's esophagus, they are getting followed up. And this is always done by, the gastroenterologist is really good, or whoever's doing the endoscopy really good at following these patients up. But the important thing is from them is to realise that that this is a pre-malignant condition and it does need surveillance. You can't let someone with Barrett's esophagus really, because you could see that there is a chance that all can step into more higher things and turn into esophageal cancer. And it's a very horrible cancer with a lot of high morbidity. And there's a lot of treatment options for, once again, you hear about this, so that's there. The other thing I suppose is, from a general practitioner's point of view, is also, it's a metaplasia. So when we get metaplasias, they are due to an injury and the body is trying to adapt to it. And trying to, say, reduce the patient's risk factors for having reflux as well is probably another good thing. So, making sure they're not getting reflux, make sure you're losing weight, all that sort of lifestyle choices is obviously, and I think it's the patients that tend to develop this, and certainly the ones that tend to go on with the dysplasias tend to fall into that group of being overweight. They tend to be males, so this you can't modify, but they tend to have, there's also maybe some evidence that they don't eat the diet as well. So there's a lot of lifestyle things that you can hopefully do and implement to reduce it. Interesting enough, so I was going to say that smoking isn't really linked in with this. That's more associated with squamous cell carcinoma of the esophagus, which is actually worldwide the most common type of carcinoma. But in this country where we have a lot of obesity, it is certainly, this is this adenocarcinoma arising from reflux in the esophagus is the most common one. That's hopefully what I would think that would be useful. Yeah, there's a lot of, they're getting followed up.
All right. Well, as the layperson, I'm thinking to myself, using Rennies 2 or 3 times a year, probably okay. Living on it, probably need to see a doctor.
That's a good thing. And I think that's a point, is that, most patients tend to be a bit symptomatic with this sort of stuff. So if you are certainly suffering from long reflux, go and get it sorted out. You don't want to end up having half your esophagus chopped out and part of your stomach.
Exactly. On that note, we now understand fully yet again why you keep winning those outstanding teaching awards. Dr. Tristan Rutland, thanks again for joining us on This Medical Life.
Thank you so much for having me.
Dr. Milan Bassan graduated with honours from medicine with the University of Western Australia in 2003. He undertook gastroenterology training at Nepean, Wollongong, Liverpool and the Northern General Hospitals, and obtained fellowship of the Royal College of Physicians in 2011. Dr. Bassan completed training in advanced therapeutic endoscopy at Westmead Hospital and therapeutic endoscopy group at St Michael's Hospital in Toronto, Canada. He has a particular interest in a variety of conditions, but today we're going to mention one specific, and that is Barrett Oesophagitis. Dr. Bassan is a VMO gastroenterologist at Liverpool Hospital and a conjoint associate lecturer of the University of New South Wales. Today, Dr. Bassan is our guest on This Medical Life podcast. Milan, welcome.
Thanks, Travis. Thanks, Steve.
I'd like to start by asking this. With so many patients who are suffering GORD in the general community, who are the patients that a GP should identify for potential Barrett esophagitis?
So surprisingly, given how much reflux there is, there's not a lot of evidence to help us with decision-making to determine who we should be looking at screening for Barrett's. Even the presence of long-standing reflux symptoms isn't that helpful, as only about 10% of patients with chronic reflux will have Barrett's. And almost half of patients who've got a short segment of Barrett's change will have no significant reflux symptoms. The current best guidelines are from the American College of Gastroenterology, and they were published last year. Unfortunately, our Australian guidelines are from 2015 now, and I think have been currently revised at the moment. But the ACG suggests consideration of screening for patients with chronic reflux symptoms and three of the following risk factors, namely a family history of a first-degree relative with esophageal adenocarcinoma or high-risk Barrett's dysplasia, being male, smoking, obesity, having an age greater than 50 years, and being of Caucasian background. They do note the quality of the evidence behind this was very low, essentially meaning it was a group of experts sitting in a room who came to this conclusion. And so to some degree, the decision to screen needs to be individualized. Certainly, if in doubt, I'd suggest referral to a gastroenterologist to discuss the role of screening would be something to consider. And then we could have a more detailed discussion with the patient about the pros and cons of a screening gastroscopy. The other thing, I guess, to point out is patients with red flag symptoms such as vomiting, dysphagia, and weight loss. We're more thinking about advanced pathology and cancer rather than Barrett's esophagus, and these patients should be referred separately for urgent assessment.
I remember going through medical school, and I don't know if this is relevant, where they actually said the people that are high risk are the people who have long-standing reflux, have this terrible issue, and then suddenly it goes away and it's fine. Is that still relevant, or is that of no use?
Look, there is this suggestion that with the Barrett's change and the intestinal metaplasia, the esophagus is less sensitive, if you like, to the effects of acids. So, and I think that feeds into these patients who don't have a lot of reflux symptoms, but probably not in itself enough to sort of push you one way or another.
Now, when you're actually looking at investigating a patient, what are the features that you are actually looking for that are suggestive on this on gastroscope?
So at endoscopy, the key findings extension of the columnar appearing mucosa. And so the mucosa in the stomach has this sort of salmon-coloured or reddish appearance. The mucosa of the esophagus looks much more white. And in a normal esophagus, we usually see this sort of slightly irregular Z-shaped line, which is the gastro-oesophageal junction. So what we're looking for is that interaction or that junction between the whitish mucosa and the red mucosa extending some distance above the physical top of the gastric folds. Once we see those Barrett's changes, the other thing we're looking for then are features of more advanced disease. And so it's essential that the segment's closely assessed to define the extent of the Barrett's and to also assess for any areas suspicious for dysplasia or malignancy, because generally cancer and high-grade dysplasia will be endoscopically visible, particularly with the newest generation endoscopes with built-in image enhancement technologies, also using topical agents to improve surface visualization. And then looking for areas of nodularity or disturbed vascular or surface patterns. When we generate reports then, the current standardized reporting language is using what's called the Prague criteria, which comes up with a C-score and an M-score. And the C-score is the circumferential length of the Barrett's change, and the M is the maximum length of the longest tongue. So if you had a patient who had 10 centimeters of Barrett's, but it was only circumferential for 4, that would be called a C4 M10 segment of Barrett's. followed by a description of any areas of ulceration, nodularity, or disturbed surface or vascular pattern to highlight where the endoscopic areas of concern are.
So then looking at the biopsies, I've seen sort of things vary from just a few biopsies taken to like multiple biopsies taken. Is there any recommended guidelines on what are the biopsies to take?
So at that initial index endoscopy, when the close assessment's been done, the first thing is to look at targeting any irregular or abnormal appearing areas and then labeling those biopsies to specify those sites, because probably the majority of adenocarcinoma and high-grade dysplasia in Barrett's esophagus is identified at the first gastroscopy when the Barrett's has been closely assessed, rather than being identified during subsequent sort of surveillance or screening procedures. So first thing is targeting biopsies. Beyond that, it's still considered standard of care to obtain what's called modified Seattle protocol biopsies. So these are taken in 4 quadrants every 2 centimeters, starting from the top of the gastric folds, extending right up to the endoscopically apparent squamo-columnar junction. Now, obviously, if you only have one long tongue, then the biopsies will just be taken along there. I think we are heading towards a future where we'll just be able to look and target, and we won't be doing these random biopsies because we end up sampling a relatively small proportion of the surface area anyway. And as we look at 4K endoscopes and then the next big thing being AI in endoscopy, and I think we'll move away from these mapping biopsies, but we're not there yet.
So there is a lot of discussion about short and long Barrett's esophagitis. Is this a useful clinical distinction? Is this a helpful classification?
So normally short and long segment Barrett's refer to segments either less than 3 centimeters for short or 3 or more centimeters when they're long. The distinction, well, the number's a bit arbitrary, but the length of the Barrett segment does make a difference, and it certainly is related with predicting the risk of progression. So when we look at very short segment of Barrett, so less than 1 centimeter, there is sort of long-term data suggesting the risk of progression to cancer if you have no dysplasia and no malignancy at the initial endoscopy is negligible. And often these patients actually have gastric intestinal metaplasia of the top of the stomach rather than true Barrett's change. With longer segments, you're basically looking at more mucosa that's at risk of dysplasia and cancer. So the endoscopy needs to be sort of done in such a way that you allow enough time, because time of esophageal inspection is also associated with detection rates of dysplasia. And it also then looks or sort of feeds into the surveillance intervals, with long and short segment Barrett's having different surveillance intervals that are recommended. And patients with very long segments of Barrett's are looking at over about 10 centimeters. Generally, these are the sort of patients who would be referred into a tertiary Barrett's center with expertise in Barrett's surveillance and therapy, just because it is quite an intensive endoscopy and biopsy process.
So then looking at patients within those classifications, so let's say we have a patient with no dysplasia, low-grade dysplasia, and high-grade dysplasia. How often are these patients recommended to be scoped?
So look, that's a great question. Again, there's not a lot of evidence around screening, diagnosis, and surveillance. Mostly evidence in Barrett's esophagus is around therapy, and I guess that's the interesting area where everyone's focused on. So as I'd said earlier, most cancer or high-grade dysplasia is diagnosed at that first gastroscopy where the Barrett's has been closely assessed. So it may not be the first gastroscopy the patient's had, but the first time where an endoscopist has gone in to closely look at the Barrett's, map it out. And so that first endoscopy is key. And if the patient's had a gastroscopy, Barrett's has been found, and they haven't had that careful assessment, then a repeat gastroscopy within 6 to 12 months, assuming that any biopsies taken haven't shown dysplasia. Following on from that, with non-dysplastic Barrett's, every 3 years would be the recommended surveillance interval for the so-called long segment, so the 3 centimeters or more. and 5-yearly for those less than 3 centimetres. When we move into the setting of dysplasia, there's a shift towards endoscopic management and a low threshold for endoscopic therapy rather than ongoing surveillance. And this is all related to the risk of progression to cancer. So baseline risk when someone without Barrett's of developing esophageal adenocarcinoma is about 0.07% per year. In non-dysplastic Barrett's, this goes up to about 0.4% per year, so it's still very low risk. Then as we move into low-grade dysplasia, and the studies on this are very heterogeneous, so it's a little bit hard to say the exact number, but most studies report 0.5 to 1%. But there's emerging data now that when you have an expert GI pathologist review low-grade dysplasia, a lot of these patients are downstage to having inflammatory change. And when you look at the patients with sort of true high-grade dysplasia, if you like, that risk of progression seems to increase up to around 4% per year. And it's somewhere in the order of 4 to 8% per year in high-grade dysplasia. So any patient who's got unexpected dysplasia should have a repeat endoscopy with an endoscopist who's familiar in sort of endoscopic technology and Barrett's surveillance, and that should be done in a quick smart, really trying to find and map out any areas of dysplastic change. And then if there's nothing obvious there, then much more intensive biopsying. So 4 quadrant biopsies, but every 1 rather than 2 centimetres. High-grade dysplasia is now accepted as an absolute indication for endoscopic therapy, and these patients shouldn't just be having surveillance. So the old sort of concept of waiting for the train crash in high-grade dysplasia and just watching till the cancer develops has basically gone out the window. There is still debate about whether low-grade dysplasia should be treated or observed, and that still hasn't been resolved. But it's really important, like I sort of hinted at before, that you really need an expert GI pathologist like Tristan to review the histology and go through, because there is significant downstaging for a lot of patients with low-grade dysplasia. Sometimes they're upstaged as well. And I guess, Travis, as you know, it's not always so simple to distinguish inflammation from true dysplasia, and then we end up with these patients who sort of get reported as indeterminate dysplasia with the flag that, hey, look, we need to keep an eye on this, but maybe can you do something more to get rid of some of that inflammatory change to give us a biopsy that's a bit more clear-cut to interpret.
Because it's a little bit hard in the area, and the GPs listening will say, okay, so I know that high grade, definitely they need intervention straight away. Is there any sort of guidance you can give GPs if they come across a patient with low grade dysplasia? How often you would say, as a rule of thumb, would probably be useful to have a follow-up scope?
So I think if the endoscopist who's done the procedures not sort of given guidance, because usually the patients will be referred on for tertiary assessment anyway, but if not, probably a repeat endoscopy in 6 months would be a reasonable starting point. And, perhaps if this has come through, say, an open access service where you don't have regular endoscopists, then think about referring on to your sort of local referral centre for further assessment of that patient. Those patients with dysplasia, probably it's not fair for us as gastroenterologists to be expecting our colleagues in GP land to be making decisions on surveillance intervals. This is a much more specialised area now. So.
Now, there is a procedure that you are considered an expert in called minimally invasive endoscopic resection. But can I ask, what are the treatment options for patients who have Barrett esophagitis?
So I guess endoscopic therapy, like I said, high-grade dysplasia is considered an endoscopically managed disease. Low-grade dysplasia, it's still debatable. But even intramucosal carcinoma and in certain patients with superficial submucosal invasive disease have all become endoscopically managed conditions. And this is a big change from when I was going through medical school, where we were taught Barrett's esophagus with high-grade dysplasia meant either referral to a surgeon for esophagectomy if they're fit, or sort of fingers crossed and hope for the best. When we look at endoscopic therapy, basically there's two things that we can do. One is resection of tissue, and the other one is ablation of the mucosa. And often we use these two approaches together to manage patients with dysplastic Barrett's. So with endoscopic therapy, the basic principle is if you have a visible area of concern, this should be resected. And if there is endoscopic concern of malignancy, this should be resected en bloc to allow for assessment of margins. And that ablation is then used for eradication of the remaining Barrett's mucosa, because there's a very high rate of so-called invisible dysplasia in the remaining mucosa, implying that there probably is a significant field change, that if you have an area of visible dysplasia, the rest of the Barrett's is much more prone to harbour dysplasia as well. And we can also look at ablating entire Barrett segments if we have no endoscopically apparent areas to resect. In terms of endoscopic resection, we can do this either by a technique called endoscopic mucosal resection, which allows piecemeal resection of the mucosa. It's quite a quick and effective technique and allows capture of up to about 2 to 2.5 centimeters of tissue with a reasonable amount of submucosa for assessment of the deep margin. And this is basically a variation on the technique used to band esophageal varices and also to band hemorrhoids. And so we have a device attached to the end of the endoscope, the mucosa is sucked up, a band's applied to create a pseudopolyp, and then using a diathermy snare, we resect it. For larger areas, particularly where there's a concern of cancer, we use a more complex technique called endoscopic submucosal dissection, and this can be used to resect larger areas of mucosa and the submucosa all the way down to the muscle in the esophageal wall. So we can get a deeper resection, and we can even resect entire Barrett segments. So we can do circumferential resections, particularly in cases where it's suspected that there's multifocal disease, and it's going to be very hard to sort of remove multiple areas and actually get clear margins around each one. This is a specialised technique, and there are some risks with this. And so particularly what we worry about are post-procedural bleeding and esophageal perforation. And the rates of these are about 2% and 1% respectively for EMR, and about double that for submucosal dissection. So it's not a simple thing, but we're really looking at these as an alternative to esophagectomy, which is a very morbid operation. Esophageal stricture formation is common after resection. So if you're a GP and your patient's undergoing this therapy, it's certainly not unusual for the patients to then need to come back and have several endoscopic dilations of the esophagus. And when we get to circumferential resections, the strictures are universal. With ablation, this is most commonly done with a system of radiofrequency ablation. So it's a sort of low-intensity thermal therapy that's applied to the mucosa. And the aim of that is basically designed to burn the submucosa and the superficial submucosa. And then as tissue heals, we're hoping that what we'll get is the normal squamous epithelium regenerating above it. And this is a really quick and safe way to do it. It's much less technically challenging than endoscopic resection techniques, but you have a couple of limitations. One is that the depth of ablation is not that deep. So if you have a raised or nodular area, you're not going to be able to ablate that mucosa successfully. And you don't achieve any histological confirmation of what you've treated, because it's just the whole thing is burnt. You don't get any pathological sample. The risk of stricturing and perforation is very low, but not zero. And there's now sort of 10 plus year data showing really good maintenance of remission of dysplasia and even Barrett's change, so loss of all of that intestinal metaplasia. But it still isn't to the point where we can ablate and forget about it. That these patients, once they've had dysplasia, still do need ongoing endoscopic surveillance.
So then can you tell me what the line is where you'll say this is actually too much from a sort of minimal resection area and it needs to be, what is the line that is sent to a surgeon?
So in terms of resectional surgery and esophagectomy, it would be invasive adenocarcinoma. Though, like I said earlier, even superficial submucosal invasive disease in comorbid patients we may manage endoscopically, and particularly if they don't have high-risk features such as lymphovascular invasion or a poorly differentiated malignancy, because the risk of those patients having metastatic disease, even sort of occult nodal disease, is probably lower than the risk of them dying from the surgery. The other thing, I guess, where we ask our upper GI surgical colleagues to get involved is looking at the role of anti-reflux surgery, especially in patients with a large hiatus hernia, because often these patients will never get good control of their reflux and their esophagitis, regardless of medications that we use, without repairing that hiatus hernia. And that underlying inflammation that drives the Barrett's and probably drives that progression to dysplasia, we really want to get on top of the inflammation. So that's probably the other setting. It's important to make sure the Barrett segment's been carefully assessed, because from a surgical point of view, the surgeons don't want to go in, do a hiatus hernia repair, and then 6-12 months later have to be looking at now going in to do an esophagectomy, and the additional adhesions and scarring makes their life much more difficult. The evidence to date doesn't demonstrate a reduction in risk of progression following anti-reflux surgery, but I think this is probably because the trials are very small and underpowered.
My goodness, it's been like a living, audible textbook with you. Thank you for the generous level of detail, Milan. But before we finish, is there any advice that you have for a GP managing a patient with Barrett esophagitis or about Barrett's in general?
So I guess in general practice, probably the biggest thing, and we haven't even talked about this yet, is the use of proton pump inhibitor therapy. And this is really the mainstay of long-term management for patients with Barrett. So looking at controlling that reflux and inflammation is really crucial in reducing the risk of progression. And there's very good evidence that PPI therapy does reduce the risk of progression. And partly this is blocking acid and reducing the inflammation, but there does seem to be probably some direct mucosal anti-inflammatory effects from PPI and possibly some anti-proliferative effects as well. And so this is why we look at ongoing PPI therapy in patients with any significant Barrett's esophagus, even if they don't have reflux symptoms or don't have visible esophagitis even off therapy. And certainly in this setting, the benefits of cancer risk reduction outweigh any potential side effects for the vast majority of patients with Barrett's. And these patients should be on PPI therapy even if they're not having any significant reflux symptoms. I think the other thing that's important in general practice, and I think general practitioners do this much better than we do as gastroenterologists, is the importance of lifestyle risk factor modification. When we looked at those sort of risk factors for patients at high risk for Barrett's esophagus, things like smoking cessation, lifestyle changes to help manage obesity are really actually very, very important in managing these patients as well and managing their underlying reflux.
Wow. On that note, Dr. Milan Bassan, thanks for joining This Medical Life.
Yeah, my pleasure. Thank you.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts via Twitter. Dr. Travis Brown is at Dr. Travis Brown. That's DR for doctor. And Steve Davis is at Steve Davis. Editing and production is by Tim Whiffen. Design is by Tom Buzenjut. This has been a PathNotes Proprietary Limited production.
Hi, Jeremy Cordeaux in the Court of Public Opinion. I'm just on air here to let you know that we'll be live streaming the Court of Public Opinion every Friday between 9 o'clock and 12 on jeremycordeaux.com. Please join us. We'd love to have you.